Welcome, everyone. My name is John Holman. I'm Vice President of Medical Affairs at Transplant Genomics. I appreciate you sharing some time with us today. Our symposium is entitled The Management of Kidney Transplant Patients Using TruGraf and TRAC for Surveillance. Our first speaker today is Dr. John Friedewald. John is the Medical Director of Kidney and Pancreas Transplantation at the Northwestern Comprehensive Transplant Center in Chicago, and he will be speaking today on the overview of TruGraf.
Thank you very much, Dr. Holman. It's a pleasure to be with everyone today, coming to you from Chicago, wherever you are in the world. Thank you for joining us. I'm going to provide an overview of the TruGraf test. I have the following disclosures. I'm a clinical advisor for Transplant Genomics, and I have grant funding from Eurofins Viracor. So what is TruGraf? TruGraf is a test that was designed with a very specific purpose. Some tests are born looking for a disease, I like to say, and others, we start with a specific disease and develop a test, and that's what we did with the TruGraf test. So TruGraf is a blood gene expression profile test developed very specifically to detect the absence or presence of subclinical rejection in kidney transplant recipients who are otherwise stable. What is subclinical rejection? Very important to define the clinical phenotype. We define subclinical rejection by three things. Number one, normal renal function, and we chose a cutoff of 2.3 milligrams per deciliter below that as normal kidney function. And there is nothing magic about that number. We chose it because we wanted to be inclusive of patients who maybe had a higher level of serum creatinine, but otherwise a stable and healthy graft, perhaps due to donor disease. So we chose that number. Number two, stable renal function, defined by a change less than 20% from prior values. And number three, rejection on a surveillance biopsy done just to check the kidney for subclinical rejection. So those things define subclinical acute rejection. And we did a study to determine this. It was the CTOD8 clinical trial. And in that study, we did two things. We developed the clinical validity of a novel blood-based biomarker for subclinical rejection following kidney transplant. We also defined the disease itself. So in a large multi-center trial here in the US, we defined the frequency and the importance of subclinical rejection. Critically, that even borderline rejection are meaningful in terms of clinical endpoints. Now, that important finding was found in our clinical trial, but it was also echoed in several other publications in the same year. So the group from Pittsburgh has published this, and actually a more recent paper looking at, again, early graft inflammation on protocol biopsies leading to poor clinical outcomes. And I'll show you what those are. Number two, a group from the University of Alabama, Birmingham, in a pediatric population looked at early rejection, subclinical rejection. And this group I'll show you later actually showed that treating subclinical rejection improved outcomes. Number three, the very large and well-designed GOCAR trial, similar to the CTOD8 trial, did surveillance biopsies in a large number of patients in the first 2 years and found, again, that subclinical rejection associated with worse clinical outcomes. And finally, the group from Australia published a similar paper, again, showing that low-grade inflammation in the kidney leads to bad outcomes. And so detecting this inflammation early and treating it is a key goal to improving long-term graft survival. So how often does subclinical rejection occur? We found in the CTOD8 trial, and this was very similar to the GOCAR trial, where surveillance biopsies were done at 3, 12, and 24 months post-transplant. And we found the point prevalence to be fairly similar at all those time points. So 20% of patients biopsied at 3 months had subclinical rejection, 25% at 1 year, and 25% at the 2-year mark. Overall, if you look at a subject level, because patients could have more than one biopsy showing subclinical rejection, 35% of patients in the study had at least one biopsy with subclinical rejection. And when we broke down the type of rejection, most were cellular rejection, T-cell mediated, and most were borderline. 70% were borderline rejection. 30% were either 1A or greater or antibody-mediated rejection, or some combination of those. So I mentioned it, but what are the consequences of subclinical rejection? Why do we care? This shows why. So we know from both the CTOD8 and the GOCAR trial, as well as the other trials I mentioned, that there's a higher risk of going on to develop clinical acute rejection after an episode of subclinical rejection. Patients who have subclinical rejection are more likely to form de novo DSA, statistically significant. They're more likely to lose the graft at 5 years, and that's shown here in the GOCAR trial, where patients at the 3-month biopsy who had no acute cellular rejection versus those that did, and this is subclinical, though those that had rejection had a worse graft survival at 5 years. They're more likely to develop fibrosis in the graft, grade 2 IFTA or greater, and that was shown in the CTOT-8 trial as well as the other trials, and a more rapid loss of GFR. And we've now followed our CTOT-8 patients out to 5 years, and we see a steeper drop in GFR, decline in GFR in patients that had early subclinical rejection. So all of these things together, of course, are early harbingers of graft loss and worse graft outcome long-term. And so we really need to focus on the early events going on in the graft to prevent those from happening. So now we know also that treating subclinical rejection improves outcomes, both subclinical antibody-mediated and T-cell mediated rejection. And this is one paper from the group at University of Wisconsin showing treating subclinical antibody-mediated rejection improved outcomes. In this study, they were looking at just donor-specific antibody development and doing biopsies based on that biomarker. And what they again found is if you treat early, the outcomes for those early treated patients are very similar to those that did not have any rejection at all. And I mentioned the group from University of Alabama, Birmingham, and pediatric patients treated pediatric patients with T-cell mediated rejection, primarily subclinical. And again, the treated subclinical rejection did better than those untreated. And so there's evidence both now for cellular and antibody mediated rejection, subclinical, that treating improves outcomes. So let's take a step back and talk about how do we discover a gene expression test? What is that? The way we did this in the CTOT-8 trial was we took a number of patients who had biopsies, 530 biopsies, all paired with blood samples. So we knew what the clinical phenotype was based on the biopsy. Then we looked at the blood samples of those patients. We had 400 patients who had a normal biopsy. We call that transplant excellent. And that's, again, stable renal function, normal renal function with a negative biopsy. And we took those that had subclinical rejection as previously defined. And then we looked at the differences in gene expression in those two groups by looking at an Affymetrix gene array. This is a whole exome array. We then filtered those genes by a bioinformatics process, and we used a random forest model that asked the question, what set of genes best tells these two groups apart based on their differential expression at that time point in the blood? It turns out the TruGraf gene expression profile consists of 120 genes that are either up or down regulated and specifically chosen to distinguish stable biopsies from those with subclinical rejection. So again, this is a very specific test for this disease, and that's important. The TruGraf test has been validated in external cohorts. This is a publication from Chris Marsh and colleagues looking at 7 US transplant centers who use the TruGraf test in the setting of patients that are stable and being biopsied. The accuracy of the result of a TX or a normal result was very accurate across the different centers. And you can see the performance was the same as in the CTOT-8 trial, a high negative predictive value about 89% and a positive predictive value of 48%. So again, the TruGraf test is very good at ruling out subclinical rejection and knowing that a patient doesn't need a surveillance biopsy, that you can do without it and know they're stable. I'm going to move on to a few examples that illustrate how the TruGraf test can be used. And in these slides, I also have data from a cell-free DNA assay called the TRAC assay. And the way this works is this is a single patient. This patient was followed for 2 years in the CTOT-8 trial. Patient had serial biopsies shown here along the bottom and TruGraf testing here. And you can see at 3 months and on the other time points. Now, the TruGraf testing in the study was not available at the time of the clinical trial. So the patient was treated based on biopsies alone. We then went back after we discovered the TruGraf gene expression assay and looked at what the TruGraf assay would have shown at those time points. And you can see this patient, the serum creatinine is shown here in orange. So a fairly normal, good, stable creatinine out to 3 months. But at 3 months, the patient had a non-TX TruGraf result, which means an abnormal result. The biopsy just showed interstitial fibrosis and tubular atrophy grade 1, but no rejection based on the biopsy read. Now, at that point, following that, the patient's creatinine started to creep up. At this point, at 6 months, the patient had a for-cause biopsy. And again, TruGraf is not indicated currently in the setting of graft dysfunction, so a TruGraf test was not done at the time. The patient went on to have a BAMF2A acute cellular rejection. Interestingly, they also had thrombotic microangiopathy. And when we look at the cell-free DNA assay, which is positive above 0.7, you can see the cell-free DNA was going crazy. What we know about cell-free DNA is it's very sensitive to, very specific for vascular injury. And obviously a thrombotic microangiopathy, there's a lot of endothelial injury releasing a lot of cell-free DNA into the circulation. And so the cell-free DNA was off the charts. Again, this was obtained retrospectively. We didn't know it at the time. The patient was treated with steroids. And because of the thrombotic microangiopathy, they were also treated with plasmapheresis and IVIG. They were given antithymocyte globulin, and their tacrolimus was discontinued, thinking that was contributing to thrombotic microangiopathy. The patient improved. The cell-free DNA improved. And the TruGraf test went back to TX after treatment of rejection here. But again, a month later, a follow-up TruGraf test, and I'll show you the value of follow-up testing after a rejection episode. The TruGraf is back to being non-TX. The creatinine went back up again. Another biopsy was done showing borderline acute cellular rejection and persistent thrombotic microangiopathy. Interestingly, at this time, the cell-free DNA was down now at a very low level. The patient was treated with anti-C5 therapy. Serum creatinine stabilized and continued to improve over the time. At the 1-year mark, the patient had another non-TX TruGraf result, and again, just showed interstitial fibrosis and tubular atrophy. They then went on to have 2 more TX results later on, again with the stabilized serum creatinine. But at the 2-year mark, they had a non-TX TruGraf result, again a biopsy showing borderline acute cellular rejection, treated with an increase in maintenance immunosuppression. So you can see how the TruGraf testing can mirror what's going on in the biopsies and eventually replace what we need for biopsies in stable patients. This is a patient who had subclinical acute cellular rejection, which eventually evolved into antibody-mediated rejection. And I wanted to show this case because I think when we think about how this happens in an individual kidney graft, we have an early cellular response, which then leads to a memory response and antibodies. And this is a great example of that. So this patient, again, had an early course that was very good. And if you, again, look at just the patient's serum creatinine, it was normal throughout the 2-year trial. So if you just were following serum creatinine, you might see that this person was doing totally fine. At 3 months, they had a normal biopsy and a TX TruGraf result, so potentially they could have been spared that biopsy. By 1 year, though, the TruGraf test is non-TX abnormal, and we find borderline acute cellular rejection. Now, at the time, it was clinician preference in the trial. It was not an interventional trial. The clinician chose not to treat those borderline infiltrates. But what we know is those borderline infiltrates, when they hang around for a while, can lead to ongoing immune response. And sure enough, by 15 months, the patient goes on to have, again, a non-TX TruGraf result, a biopsy done because they developed some proteinuria, and they're found to have borderline acute cellular rejection, which is persistent. And now they develop the antibody-mediated rejection and a new de novo donor-specific antibody. At that time, also, the cell-free DNA is positive at a level of 1. The patient's treated with steroid pulse, IVIG, and rituximab. You can see the cell-free DNA, which was tracked, went up to 8 and up to 10 eventually. Now, some time goes by. At the 2-year mark, they have another surveillance biopsy with, again, stable serum creatinine. The TruGraf is still not TX abnormal. The biopsy still shows AMR. Cell-free DNA is high, and they're treated again with another round of steroids, plasmapheresis, and IVIG. So again, showing a lot can be going on with stable serum creatinine that you'd be missing if you weren't looking deeper, either with biopsies or with biomarkers. And the message here is that biomarkers can often spare patients biopsies when they don't need them, or indicate when they're needed and to diagnose disease early. Here's a patient that was a highly sensitized patient who underwent pre-transplant desensitization for an HLA positive cross-match. I just want to illustrate this because this shows how, again, gene expression profiling like TruGraf can work in conjunction with cell-free DNA. So again, this patient early on, again, had a perfectly good course in terms of their kidney function, very stable and normal serum creatinine throughout the 2 years. But again, if you dig deeper, you see that cell-free DNA, which is normal at 3 months, is up by 6 months above normal. And then you have a spike here by 9 months, but because the protocol was stable kidney function, they only had a biopsy at 12 months. At that time, the TruGraf test is abnormal, not TX. The biopsy shows subclinical antibody-mediated rejection. Patient is treated with rituximab and IVIG in the face of stable renal function. Cell-free DNA, which again was found retrospectively, was still high this whole time. They had a follow-up biopsy in 3 months per the clinical protocol. Again, the TruGraf is still abnormal, not TX. Biopsy still shows subclinical AMR. They're treated with additional rounds of intravenous immunoglobulin. Cell-free DNA now comes down. And by the 24-month time period, they got a normal biopsy with a TX TruGraf result. I think this is a great illustration of how both biomarkers can help track the course of a patient over time and inform interventions. Okay, I mentioned follow-up for treatment. So in the CTOT-8 trial, all patients that had subclinical rejection of either type had a follow-up biopsy at 8 weeks, and that's shown here. So here, all the patients at biopsy time point had subclinical rejection, either cellular or antibody-mediated. They all had blood sampling every 2 weeks at these intense monitoring visits, and then at 8 weeks, they had a biopsy. And what was surprising is after 8 weeks, only half the patients had resolved their rejection based on histology. More than half, 52%, still had ongoing rejection at the time, even though, again, these patients all have stable renal function. What we also found was interesting is if you look at the biomarker, which is the positive negative line is here, the groups that resolved their rejection, shown here in red, versus the group that had unresolved histologic rejection in black, a couple interesting things emerged. Number one is at the baseline biopsy, about half the patients who had resolved their rejection had a negative biomarker to begin with. And again, the biomarkers were done retrospectively. But almost all the patients that didn't have resolution of rejection had a positive biomarker at baseline. By the time treatment was done, again, most of the people that did not resolve still had a positive biomarker, where most of the patients that had resolution had a negative biomarker. So what this tells us is we can then monitor patients after treatment. I showed one example of that in the previous clinical example, how the biomarker can tell you whether a patient has had resolution or not of rejection after treatment. So how do we use this test, a monitoring algorithm? You have a lot of patients, and I think of this like a shepherd. You're shepherding your flock, and there are a lot of them. What do you do? How do you monitor them? How do you know what to do? So the TruGraf can help you decide what to do. So you do a TruGraf test on your stable patients, and many of them, about 2/3 to 3/4, are going to have a negative test. Those patients can simply be reassured and monitored without needing an invasive protocol biopsy. And again, as LPP, not only do they spare a biopsy, but they also get that reassurance, which for patients is really important to tell them you're doing okay. Then you can take the smaller group of patients, which are more manageable, and say, you've got an abnormal test result. We probably should do further evaluation, whether that's a biopsy or other testing or treatment, such as adjustment of immunosuppression, baseline immunosuppression. But at least you can focus your efforts on patients who need more of your attention and reassures those that are doing well. So in summary, subclinical rejection is common. About 1/3 of the patients have it in the first 2 years of their transplant. Was previously only detected by surveillance biopsies and is associated with inferior graft outcomes. Further episodes of rejection, development of de novo donor-specific antibodies, lower GFR, fibrosis, and graft loss. Monitoring with the TruGraf test can provide confidence that your patient's not having subclinical rejection and alleviate the need for invasive surveillance biopsies. And early detection of subclinical rejection and treatment improves outcomes. Thank you very much for your attention. I'd be happy to take any questions.
So Dr. Friedwald, that was a very excellent talk, as always. I noticed one of your cases that you identified had a non-TX TruGraf assay in the face of a stable serum creatinine, but they had IFTA on the biopsy. Could you comment on the picking up of IFTA with the non-TX TruGraf assay?
Yeah, Dr. Holman, thanks for the question. And, I think in that case, this was an early time point. So just addressing the IFTA on the biopsy, my guess is that's probably donor-related disease that came along with the kidney. It was a deceased donor kidney transplant, so that's probably the most likely explanation there. The non-TX abnormal TruGraf result, it's unclear. So one of the analyses we're doing currently is we're looking at serial samples prior to rejection to see how early a TruGraf test would turn abnormal, not TX, before a rejection episode. So those data are forthcoming. Stay tuned. At that point, though, it could be considered a false positive. But again, we don't know if that was a harbinger of things to come because that patient did go on to develop rejection later on.
I think this is a very exciting technology, and the application of precision medicine to kids, I think, would be very important. They have issues that we're all familiar with non-adherence and actually the potential for under-immunosuppression just as they grow up and their metabolism changes. What do you think would be the application of this technology to children?
Yeah, thanks. That's another great question. And, I'll say again that we've been for so long working with non-specific markers of injury to the kidney, which are very insensitive to rejection. And so to have a test that is specifically designed to detect that phenotype, I think is a real step forward. It couldn't be more so in children because, obviously, biopsying a pediatric patient is riskier than an adult patient. They often need anesthesia for the procedure, whereas we typically in our practice just use some local anesthetic for a biopsy. And so I think, being able to, number one, more safely monitor the graft of a young patient, but number two, of course, pediatric patients have much more runway with their transplants, and detecting early immune activation and injury is all the more important for them to make their graft survival even longer. And again, where we started was long-term graft outcomes are not good. Why? Oh, it's because of early graft inflammation and injury. And so we're really focusing way upstream from the problems that happen later on to try to prevent them from happening. And this is one way to do that. So we hope there'll be a great application for pediatric patients.
Thank you, Dr. Friedwald, for your presentation. We really appreciate you spending their time with us. Thank you. Our next speaker is Ethan Morin. He is an assistant professor of medicine and nephrology at the Yale School of Medicine and is an active researcher in the field of renal physiology. And he is going to speak to us on the TruGraf experience at Yale.
Hi, this is Ethan Marin. I'm in the section of nephrology and part of the renal transplant program at the Yale School of Medicine. And today I'm going to talk to you about our program for non-invasive monitoring of renal allograft function. Brief disclosure, as shown on the slide here. So at Yale, as with most transplant programs, we very intensively monitor our transplant recipients after the transplant event. We have frequent clinic visits in the first few months after transplant, including 2 a week for month 1, 1 a week for the second month, and 2 in the third month, followed by monthly visits thereafter. We do a lot of lab studies, creatinine, urinary albumin, et cetera, during this period of time to keep an eye on graft function. Typically at 6 months, our protocol is to do a biopsy at that point if everything is going well, and we do for-cause biopsies at any time during this first year. So why do we do a protocol biopsy at the 6-month point? The logic is that creatinine and proteinuria, while useful, are relatively insensitive and non-specific biomarkers for rejection and other pathologies. And there's literature to suggest, albeit with some controversy, that significant fractions of newly transplanted patients have subclinical rejection, meaning rejection even in the presence of normal creatinine and other parameters. Further, subclinical rejection is thought to be associated with worse graft outcomes. So the feeling is that if we can pick up this subclinical rejection through a protocol biopsy and modify our treatment or treat the rejection, that we can improve graft outcomes. Biopsy is at present the gold standard for detection and characterization of renal pathology. It allows for the detection of not only rejection of various kinds, but also tubular atrophy and fibrosis, tubular damage from other causes, as well as a variety of different infections in the kidney. So as mentioned, we do protocol biopsies at 6 months, and we do treat when we find rejection, not only cellular rejections and antibody-mediated rejection, but we also treat borderline rejection, typically with the steroid pulse and TAVR, as well as intensification of basal immunosuppression. Biopsy, although it gives a lot of information, does confer a fair bit of risk. The primary risk is bleeding. The allograft is a very vascular organ, of course, and bleeding can occur within the kidney, around the kidney, into the urine and other places. As a result, damage to the allograft may ensue, and you can also damage surrounding structures such as bowel. The risk of biopsy is heightened in many of our patients who are either on anticoagulation or have anatomic reasons why biopsy is more challenging. Biopsies involve a lot of stress on the patient in many cases and involve a fair bit of clinical resources in terms of clinic space, clinician time, other staff time, ultrasonography, et cetera. Lastly, the interpretation of the biopsy can be challenging. There is sampling error that can occur, and further, there's well-documented inter-observer variation in the reads of biopsies amongst pathologists. As an example of some of the risk of biopsy, I include some ultrasound images from a recent complication of a biopsy in our own practice, in which a large subcapsular hematoma formed in a patient, necessitating operative evacuation. So part of the story is to the usage of non-invasive means to monitor allograft function in our practice relates to COVID-19. So we're located in New Haven, Connecticut, just 70 miles from New York City. And we were very hard hit by the first wave of the COVID outbreak in the United States. Connecticut had over 35,000 cases and 3,000 deaths. Yale New Haven Hospital had at its peak over 400 COVID positive inpatients and a MICU service that nearly tripled in size to accommodate this patient flow. This greatly affected our transplant workflow. We suspended all transplants for several weeks. Transplant clinic visits were severely curtailed and replaced with telehealth visits. And in this environment, doing protocol biopsies, as per our usual routine became difficult to justify. And this led to an acceleration of a process that was already underway for us, which is an examination of non-invasive methods of detecting subclinical rejection that we could use in place of protocol biopsies. So broadly speaking, there are two different methodologies of commercially available non-invasive tests for rejection. The first is to look for donor-derived cell-free DNA in peripheral blood. And the principle here is that when an allograft is injured, it releases more cell-free DNA into the bloodstream. And that DNA can be picked up and identified using next-generation sequencing techniques. And there's been a number of studies and a number of different companies that have developed this type of product. Most of the studies have been done in the context of for-cause biopsies. And the data have shown that cell-free DNA is pretty good at detecting rejections that involve the vasculature, such as advanced cellular rejections and antibody-mediated rejection. It's also useful in determining whether antibody-mediated rejection is present in the setting of de novo DSA development. However, these tests have not been well studied in the context of normal graft function and have been shown to be relatively insensitive to picking up more subtle forms of cellular rejection, such as BAMF1A and borderline rejections. The other major approach to non-invasive detection of rejection is a peripheral blood gene expression profiling test. And the principle of these tests is that gene expression profiles from a suite of genes identified in peripheral blood can be used to identify subclinical rejection. A couple of different groups have similarly developed gene expression profiling tests. The group at Northwestern, as shown in the Friedewald paper in AJT from 2018, developed a test that was subsequently commercialized as a TruGraf test. This test was specifically developed to detect subclinical rejection and was tested and developed specifically in patients with stable graft function, meaning a creatinine below 2.3 and less than a 20% change in creatinine in the time before the test was done. And the principle of this test was to pick up subclinical rejection so as to forego the need for routine protocol biopsies. And the test characteristics have been developed such that the negative predictive value of the test is designed to be quite high, 80 to 90%, although the positive predictive value of the test is only about 50 to 60%, depending on the prevalence of rejection in that population. Of note, the test is presently constituted is returned in binary fashion, either a positive test, meaning a non-transplant excellence, suggesting that there's rejection potentially occurring, or TX, transplant excellence, meaning the test is negative and the chances of rejection are only 10 to 20%. So at Yale, on the height of the COVID-19 pandemic, we elected to suspend our protocol biopsy program, and we substituted a peripheral blood gene expression profile test at the 6-month mark in lieu of a protocol biopsy. And our workflow was to follow up positive tests with a biopsy, and negative tests on patients were monitored per usual practice. For-cause biopsies continue to be performed when indicated. Further, for patients who had new DSAs or who needed for-cause biopsies that were deemed to be quite risky, we typically did a cell-free DNA test. There were some challenges to moving to this new mode of testing that we encountered. The first was that we had to incorporate the gene expression profile test into the electronic medical record at Yale so that we could facilitate its ordering and also the return of results. This took some time to achieve, but ultimately it's been set up and is working quite well. The second issue has been insurance coverage. Medicare pays for the TruGraf test, but many other insurers either do not or require lengthy and challenging pre-authorization process, which unfortunately has limited, in some cases, our ability to use this test in patients who do not have Medicare coverage. In addition, it's a new test, it's a new technology, so there's been a learning curve and a period of education and gaining familiarity with the test that's needed to occur amongst all the members of our transplant group, including not only the nephrologists, but our surgical colleagues and the nurse coordinators who work with the team. So our experience to date is as follows. We've ordered about 31 tests on 29 patients. About 2/3 of those tests were done around the 6-month mark, meaning as part of our traditional protocol biopsy timing. 2 of those 31 tests came back as not performed. There were technical issues with the test or with the sample collection that precluded returning of data. One of those 2 cases, a subsequent test was sent and was performed adequately. So it's something that can happen, but is relatively infrequent in our experience. All but 6 of the tests that were sent returned as a transplant excellence. 6 of them from 5 different patients, however, came back as not TX. And amongst those 5 patients, 3 of them have been biopsied at this point. And 2 of the 3 biopsies actually returned as a 1A rejection. So in 2/3 of our positive tests where we've been able to do a biopsy, we actually did diagnose rejection in patients who otherwise appeared to be doing well. Beyond those 3, we have 1 patient who's awaiting biopsy, and we have another patient who is electing to repeat their peripheral blood gene expression profile prior to proceeding to biopsy. So to summarize our experience to date, about 80% of the tests we've ordered have been negative, which I think is to be expected in a group of patients without biochemical evidence of rejection. About 7% of the tests, of the patients rather, that we have tested with TruGraf have turned out, in fact, to have rejection, which again is in line or maybe even on the low end of what's been published in the literature. And also of note, 25 of the 29 patients have not gotten a biopsy and at this point are not scheduled for a biopsy either. And in those 25 patients, the TX result that we got from the test has allowed us to have some measure of comfort that rejection is less likely in that group. I'd like to briefly share a couple cases to illustrate the way in which non-invasive testing has affected individual patients in our practice. So the first is patient FB. This is a 69-year-old man who developed end-stage renal disease due to diabetic nephropathy and underwent a deceased donor kidney transplant that was complicated initially by delayed graft function requiring dialysis. Further, the early postoperative period, even after graft function took hold, that early postoperative period was characterized by several AKIs and hospitalizations. That led to 2 different biopsies in the early months after the transplant, both of which showed not rejection, but just tubular injury. And ultimately, it was felt that the patient's graft function was affected by intermittent congestive heart failure exacerbations that were associated with worsening aortic valve stenosis. So at about 4 months after transplant, the patient went a percutaneous aortic valve replacement, a TAVR procedure, with subsequent stabilization and improvement both in cardiac and renal function. So as the 6-month time point rolled around, we proposed a protocol biopsy to this patient who was already somewhat gun shy after having had 2 prior biopsies, and he was not enthusiastic about doing yet another biopsy. So we ordered a gene expression profile test at that 6-month mark, and it returned as not TX, suggestive of a possible rejection. Sure enough, we did a biopsy, and it came back as acute cellular rejection, BAMF class 1A, and he was treated with a steroid pulse. Second case, MP. This is a 24-year-old woman who has ESRD due to congenital abnormalities of the urinary tract leading to chronic reflux and scarring of her kidneys. She had a preemptive living-related donor transplant that went very well. At the 6-month mark, she refused to have a protocol biopsy. She is, I think, as are many young patients like this, somewhat headstrong, not enthusiastic about medical tests. And we eventually persuaded her to undergo a TruGraf test, a peripheral blood gene expression test in place of the biopsy. This test also returned as not TX. And we subsequently convinced the patient to undergo a biopsy on the strength of those test results, suggesting that her chances of rejection were substantially higher than had the test come back as TX. Patient then did agree to a biopsy, which actually found no evidence of rejection, but nonetheless, I think both the patient and the care team were more satisfied with this workflow than if the patient had simply refused a biopsy and we were unable to obtain any more information. What comes next? As I mentioned, our particular center's movement into the use of non-invasive tests of allograft function was motivated in large part by constraints imposed upon us by the COVID-19 outbreak. But even as that outbreak has receded, I think that gene expression profiling and cell-free DNA are going to be part of our toolkit for allograft monitoring going forward, as illustrated by both of those cases that I just discussed. There are studies underway to characterize the performance of these different tests of rejection in a wider range of clinical settings with greater numbers of patients. There's a number of new tests under development, some of which combine different types of analysis or look at other biofluids such as urine. So ideally, future iterations of these tests will improve upon the sensitivity and specificity. And ultimately, we look forward to studies that are able to show that the use of non-invasive testing can improve hard outcomes like graft and patient survival and are cost effective. So with that, I will conclude and take any questions.
Thank you, Dr. Marin, for that presentation. I have a couple of questions maybe as the questions on chat are coming in. Is COVID still affecting your biopsy practice?
At this point, the COVID-19 numbers in our local area in Connecticut have diminished substantially. We have fewer than 5 patients probably hospitalized at this point. So our practice is largely back to normal with regard to the biopsies. But as I mentioned, the experience we gained with gene expression profiling and cell-free DNA has made it such that we continue to use these tests, even though our biopsy practice is available once again as COVID-19 has receded.
Are there situations where a biopsy is not pursued in the setting of a positive gene expression test?
Yeah, so the question as to how to use biopsies in conjunction with the gene expression profile testing is one that's evolving. Our general practice to this point has been a suggestive biopsy in cases where the gene expression profile test is positive, reasoning that the pretest probability that we're going to find something is fairly high as a result of that positive test. There are cases where patients want more information, or we feel clinically that we need more information, and we elect to wait for a repeat gene expression profile test, typically a month later. If a second one's positive, we generally push very hard to get a biopsy done in that situation. To this point, we have not treated ever without a biopsy. We always have done a biopsy and not relied merely on biomarker testing results.
What is your sense of the patient attitudes and responses to gene testing? How do they feel about it?
So far, I think the response of patients has been very positive. As I mentioned in the talk, a lot of patients are anxious or uncomfortable about pursuing biopsy and are very open to doing a non-invasive test that we feel can help guide the true need for a biopsy. The tests do require some additional education to the patients since they are sort of a newer product, new to us and new to them. But in general, I think patients are very receptive to having these sort of tests done and are appreciative to have that option in cases where there's reluctance to do a biopsy.
When do you repeat the genetic expression testing to confirm a positive test versus proceeding straight to biopsy versus initiating treatment without a biopsy?
In general, we, on the strength of a single positive test, have been proceeding to biopsy. So far, there's not been any cases where we've elected to treat just based on the results of a gene expression test. Occasionally, as I mentioned, we will wait and repeat a gene expression profile test a second time, and we've done that in situations where the biopsy is especially technically difficult, or the patient is especially resistant to a biopsy. We've reasoned that if other parameters are stable, it's safe to wait an additional month or so to repeat the test and make a decision about biopsy based on the results of that repeat test.
Thank you, Dr. Marin, for those remarks. I really appreciate you sharing some time with us.
Today, I'm going to speak about potential value of biomarkers in pediatric renal transplantation. These are my disclosures. It's all in terms of research grant support, as you can see. In essence, relatively little is known about the validity, utility, and reliability of immunological biomarkers in pediatric renal transplantation. There are some unique clinical characteristics of pediatric organ allograft recipients that suggest that immunological biomarking would be particularly helpful. There are really two big classifications. Number one is missing the diagnosis of smoldering subclinical rejection. As we all probably know, serum creatinine as a measure of renal function is the only biomarker that we use in renal transplantation today, at least in children, but it is sorely deficient. For example, small recipients of large adult kidneys have a major problem. In spite of sometimes significant rejection activity, the creatinine does not increase because of the large amount of renal reserve. Thus, smoldering subclinical rejection can go on without detection by the serum creatinine. Moreover, as children grow, they add muscle mass, which leads to an increase in creatinine. So we always ask ourselves when we see this, is this physiological changes, or are we actually watching smoldering subclinical rejection? Another unique clinical characteristic that leads to smoldering subclinical rejection are the facts that children may be unknowingly under immunosuppressed as time goes by. For example, if a child is growing, the tendency of the medical team is still to keep the immunosuppression unchanged rather than serially raising the medications pegged to the child's size, BMI, or height. This may lead to under immunosuppression and subsequent rejection. Moreover, and this is probably the big bad actor, as many as 65% of adolescents manifest significant non-adherence, leading to unrecognized under-immunosuppression and subclinical rejection. This is a particularly large problem, certainly in adolescents, but also perhaps unknowingly in adults. This is a slide I always like to show when I'm giving a talk like this. A study in transplantation about almost 10 years ago now from Beth Foster. And what Beth showed is that after the first post-transplant year, adolescents have the highest graft failure rates of any age group. As you can see, this is the incidence of graft failure at a specific age, not when the patient was transplanted, but at the age the patient is now. And as you can see on the top half of the graph, At any time, the patients that are in mid-adolescence to young adulthood have the largest graft loss. Moreover, if you factor and take the data out from the first year and put only those patients that made it through the first year, you can see again that the large, significant number of patients that are failing allografts are greatest in the mid-adolescence to young adulthood. And this is the fact of graft loss is the most of in any age group. So a number of us have been asking the question, can protocol biopsies or validated biomarkers help uncover adolescent non-adherence and help block this loss, this huge loss of transplants? So the question comes up, who does protocol biopsies? How many of us in pediatrics have actually gone to it? I'll not be commenting on what the adults do. This is just what we do in peds nephrology. And this is a very unscientific survey. I basically just went on our listserv and said, okay, how many of you do protocol biopsies? Period. I didn't want to tax people too much because they wouldn't answer the survey. And as you can see, I got 67 responses over about 3 or 4 days. Of importance, shown in red, is that in the United States, about 38% of centers perform protocol biopsies. And overall, when we take in the world who answered, 34% of the centers perform protocol biopsies, and 66 of the centers do not. In North America, both US and Canada, 43% of the centers perform protocol biopsies. This is the gold standard biomarker that we've all been using for the last 10 to 15 years. Now, we looked in a study that I published about 2 to 3 years ago in HAT. We looked at subclinical alloimmune failure events. And by that, I define that as either biopsy-proven rejection or de novo DSAs. And we did protocol biopsies in 106 pediatric renal transplant recipients at 1 year and 6 months. And we combined the data together, and what this showed was that in 22 of the 106 patients, there were de novo donor-specific antibody. Moreover, when we did biopsies in patients that had no elevated creatinines and no signs of rejection, 24 of the 106 had some evidence of inflammation or mostly T-cell mediated rejection. Of those 24, 14 had only borderline changes. Again, subclinical inflammation. 7 patients had both donor-specific antibody and biopsy proven rejection. So why is this important? Mike Seifert showed that in pediatric renal transplant recipients, subclinical rejection in whatever form in protocol biopsies are associated with a significantly increased incidence of biopsy-proven rejection and or allograft loss at 5 years post-transplant. So these kids are certainly at risk, and this is the reason that the centers do the protocol biopsies. Moving on, the question comes up, what are the emerging biomarkers in transplantation that have relevance to pediatric renal transplantation? And again, I would like to focus your attention on what is shown in red. And what is shown in red right now is that only, I've listed under the biomarkers peripheral blood, serum, and urine tests. I've listed in the middle the reliability of those tests as manifested by the AUC of the validation studies. And then I have some comments that I will just briefly go through. The short answer to all of this is there are really only 2 pediatric studies that have ever looked at any biomarkers other than creatinine. One is de novo donor-specific antibody, and there are pediatric studies that have looked at this. It's not very sensitive. For that matter, it's not as specific as we would like. And the association with de novo DSA is associated with antibody-mediated rejection. Tom Bled-Hansen, one of my ex-fellows and now a real luminary in the area of biomarkers in pediatric renal transplantation, studied CXCL10 protein in the urine and showed that there was a high positive predictive value for the urinary CXCL10. To my knowledge, this is the only study that has looked at just pediatric patients. Now, if we look at Minnie Sarwal's K-sort, the second entry on the biomarker page, or if we look at CXCL9 RNA or protein, shown by workers who have been in the CTOT study, children were examined, but the children weren't separated out and looked at separately. So while children sort of officially are in these studies, there really is no good data that tells us whether we can use these biomarkers in pediatrics to examine or to look for subclinical rejection. I've listed the others there for you. The other thing I'd like to sort of focus you on is the fact that most of the biomarkers that have been looked at in adults, essentially, have been those with high positive predictive values, whereas TruGraf has a high negative predictive value. And we're going to look in just a minute at how that may help us in pediatrics when we try to discriminate those two. Now, if we look at biomarker predictive values in pediatric renal transplantation, and I make the warning that I am by no means a biostatistician. I am the village idiot when it comes to biostatistics. However, it's easy enough to understand that if there's a positive predictive value, this will help us identify the percentage of individuals who have a positive test. Those actually have rejection or graft inflammation if their positive predictive value is within the relevant range. On the other hand, the negative predictive value expresses the value of the true negatives. Namely, if a test is negative, then the negative predictive value yields the percentage of individuals with a negative test who do not have rejection or graft inflammation. Put another way, the question can be asked, does a negative result truly mean that there is a high probability of the absence of rejection? The higher the test's negative predictive value, the more likely that that negative predictive value indicates that the patient is adequately immunosuppressed. And I stress those words, adequately immunosuppressed and unlikely to have subclinical rejection. As I pointed out before to you, the major problem we have in pediatrics is knowing that a patient has adequate immunosuppression on board. Thus, the result of a negative test in an assay with a robust negative predictive value would indicate whether the immunosuppressive regimen a pediatric patient is taking is sufficient to prevent rejection activity. I mentioned TruGraf before, and it's important to note that TruGraf does not provide a prediction of whether there is rejection, actual rejection in the transplant, because the positive predictive value is relatively low. The negative predictive value is quite high, but the positive predictive value is not particularly dramatic. Thus, it may be possible to consider pairing TruGraf with a test with a high positive predictive value to get a full and complete picture. However, the high negative value in a test like TruGraf provides a statistical assessment of the probability of whether there is no rejection activity, namely immune quiescence. And that's really what we're looking for in our patients. So how might a robust biomarker program affect management of the unique challenges in pediatrics? Well, suppose we have suspicion of medication non-adherence. In adolescence, it's very, very frequent. I like to say that whenever you have a statistic in patients of non-adherence, you always want to double it for the actual realistic amount of non-adherence. So I said before that 65% of adolescents are officially identified as non-adherent. If you double that, it means over 120% of adolescents are non-adherent. I think you get my point. The problem, of course, with non-adherence is that there is possible immunosuppression. So how would we apply a biomarker in this situation? An assay with a high negative predictive value would be very useful here, because if the result is in the negative range, this would indicate no rejection and that the patient is sufficiently immunosuppressed. Thus, no biopsy would be necessary. And again, I'm pointing this to only patients that are clinically quite stable. What about when the serum creatinine increases with growth or increased muscle mass? This happens mostly in prepubertal children that are transiting into adolescence, and this happens very frequently. And we look at the serum creatinines and we say, oh my gosh, do we need to biopsy this patient? And we often do. The increased creatinine leads to concern that there is subclinical rejection episode. Thus, an assay with a high negative predictive value would be useful, because if it's in the range of negativity, then there's likely to be no rejection, and we don't have to chase a marginally high increased serum creatinine. No biopsy is necessary because the patient is sufficiently immunosuppressed. What about the failure to adjust immunosuppression upwards with growth? Again, this happens in prepubers and adolescents, mostly in this situation as prepuberals are transiting into teenagerhood. The problem, again, is possible under immunosuppression. And if the result is in the negative range again, there's no rejection and the patient is sufficiently immunosuppressed with no biopsy that's necessary. You can see there's a bit of a theme here of wanting to uncover the possibility of under immunosuppression. Under immunosuppression that may not have mediated any clinical changes, even subtle clinical changes. And so if you can avoid the biopsy because you can feel fairly confident that there are none of these subtle clinical changes, you're ahead of the game. Finally, there's the situation in children around and less than 5 years of age when we transplant a large adult kidney into small children. In this situation, rejection activity may be missed because creatinine fails to increase because of the large renal reserve. In this situation, you'd probably most likely to have an assay with high positive predictive value. In this situation, if the result is in the positive range, there's occult rejection and biopsy is probably necessary. This is quite common in the very little kids that we see. Well, we don't do many of them because most of the transplants are done in the kids 6 to 12 and 12 to 21. That's when most of the pediatric transplants are done. The younger ones create this sort of problem. So finally, a few caveats and conclusions. With few exceptions, biomarkers with both positive and negative predictive values have not yet been validated in pediatrics. And so everything that you've heard today has to be regarded as speculative. It's possible that a test with a negative, with a significant negative predictive value, such as TruGraf, while potentially quite useful, can be improved by pairing it with a test with a significant positive predictive value, such as CXCL9, CXCL10, or donor-derived cell-free DNA. But most importantly, biomarkers with a robust predictive value have the potential to substantially improve the clinical management of some important conundrums in pediatric transplantation that we all have been faced with for a lot of years, and have to answer the questions with protocol biopsies. These biomarkers can potentially avoid the use of many protocol biopsies, and probably in terms of proportionality, we have more of these patients proportionally than do adults in their clinic because of the reasons that I told you. Now, currently validation for TruGraf and others, including a few positive predictive value studies, are currently ongoing, not just with my group, but with a number of other groups. That ends my talk, and I want to thank you all very much for listening, and I'll be glad to answer some questions.
So Dr. Ettinger, that was an excellent presentation, and you've very succinctly highlighted the unique challenges that face clinicians in managing pediatric patients. But with regard to the non-adherence, how frequently do you think you would have to monitor biomarkers in a pediatric patient to identify possible medication non-adherence?
John, that's the big question. We've been doing transplants in children and adolescents for over 50 years. And we really don't have a good answer to how long non-adherence has to be going on to give you graft dysfunction. What happens in reality in the real world is that centers after 1 to 2 years see patients every 3 months. And what happens is that after one of these 3-month interregnums, the patient comes in and the creatinine, instead of being 1.5, is now 5.5, and the patient's hypertensive, et cetera, and you're well on the way to losing that allograft. But you can't see them every 2 weeks or every month, even though you certainly would like to. So what it boils down to is what are going to be the performance characteristics of the biomarkers that you're going to talk with, and how easy are the samples to get, and how expensive is the test, and how practical it is to be able to monitor them more frequently than what you're seeing. Once we're going to need to do studies to be able to learn just how often it's going to be that this is going to be really the most helpful.
So thank you. So would a patient non-adherent with his medication regimen be actually compliant with the biomarker testing program?
Absolutely. The truth of the matter is they would. These kids come in every 3 months. They tend to forget their medicines for all numbers of reasons. And when they come in, they market themselves to you as being totally compliant. So you only learn that there's a problem when there's a huge problem. If you were able to draw bloods at home, or get urine at home, or get something in a close lab to where you live. And we're able to see the doctor rather than every 3 months, maybe every 5 months or 6 months, because you're monitoring them with reliable biomarkers. The adolescents would love that. And you could even do your visits, your clinic visits, if you will, virtually. So yes, I mean, the biomarkers will make following patients a whole lot easier.
And one last question. Bob, would you comment on the possibility that TruGraf testing or other biomarker testing in a non-compliant adolescent would teach us something about operational tolerance?
That's a very interesting question. We have patients we know are not taking their medicines, and yet their creatinines stay relatively constant. And so the question is, but frequently we don't know how non-compliant they are, or really truly if they're compliant or non-compliant. And the biomarkers of whatever stripe can help us determine what patients we need to look at more closely with immunologic testing and T cell phenotyping, B cell phenotyping, et cetera. But rather than do these on all the patients, some of whom are on immunosuppressive meds and some are not, if we can denote that the biomarkers help us figure who the patients are who are adequately immunosuppressed, but are not taking their meds, those are the ones we want to study.
So that's very interesting. Some of us have been around long enough to have this as a goal for a long time. Maybe the molecular markers and other markers will be the tool that will let us gain insight into this process. Thank you very much, Dr. Ettinger, for your remarks. And that concludes our program today. We really appreciate everyone joining us and hope that you found the presentations helpful. If you have any questions, please don't hesitate to reach out and contact me at Transplant Genomics. My email address is johnholman@eurofensus.com. And again, I want to thank you for your time, and I wish all of you to be well. Thank you.